for everybody who's coming and people will come on. I'm Lonnie Zeltzer, and I'm the moderator, and we have a great guest, expert. But first, I want to talk about sort of the mechanics. Thanks for coming, and this is on understanding migraines in adolescents. And those of you who are new to CHIP, we're a nonprofit online organization. Our goal is to empower youth who are living with chronic pain and really using sort of a biopsychosocial model of education, creative healing experiences, and peer support. I want to introduce our expert, Dr. Blake Windsor, who's a pediatrician, who actually is probably the only real pediatrician who had a fellowship in pediatric pain in Boston in the anesthesia department. He's a headache specialist and a pain specialist. He's chief of pediatric pain medicine at Prisma Health. He's clinical associate professor of pediatrics, anesthesiology, and psychiatry at University of South Carolina in Greenville. And he's owner of Brain Body Health Alliance. And this is a practice for young adults for disorders of the brain-body interface like pain and headaches. So thank you, Blake, for joining us. And there are little housekeeping things I just want to comment. Please put your questions in the Q&A section throughout the webinar, and I'll incorporate your questions as I ask Blake different questions from the audience. And our webinar is being recorded, and all previous CHIP webinars are available on CHIP's YouTube channel. Thank you for joining us, and why don't we start? And maybe we can start with understanding migraines. You know, we're talking about migraines. What is a migraine and how is it different from other kinds of headaches?
Sure. So thank you, Dr. Zeltzer, for having me here. I love talking about headaches. It is a really complicated pain condition, but at the end of the day, most causes of headaches are essentially just different types of pain with a different way that we structure it between different specialties. So what is let's talk with what is a headache? A headache is just pain in the head. Now, when I start thinking through somebody who's had pain in the head, I like to think of it as pain that is outside of the skull, meaning the sinuses, the skin, the muscle tension, maybe nerves that are irritated, and then pain that is coming from inside of the skull, meaning the blood vessels, the spinal fluid, the meninges, the lining around the brain, and then the brain itself. Interestingly, the brain tissue doesn't have any pain fibers in it. So when we talk about within the skull, we're not necessarily talking about something hurting in the brain tissue. It's often from whatever that is affecting the parts of the brain that do have pain fibers. So when we think about a migraine is a neurovascular pain, which means it's coming from the nervous system and the blood flow system within the brain. And I like to talk through when I'm describing this to patients, just from start to finish, a very classic migraine. So we're not getting into the chronic daily headaches and the chronic migraines, which are cycles of pain, which may or may not stop. We're just going to talk about a run-of-the-mill migraine. So a migraine that has a start or a stop generally starts to have some nervous system activity that starts getting excited. When people can sense that excitement, it's in that nervous system activity is in a part of the brain where we have a sensation like vision, we'll often experience it as an aura. People might look off, they'll see little spots or dots or have squiggly lines. You can also have these sensations in the parts of the body where we feel things. So people might feel numbness or might start feeling tingling before they have a migraine. And that's actually the start of the migraine. the nervous system activity. Now, those nerves start communicating with each other, and the nerve signals start spreading across the brain for about, 15 to 30 minutes or so. It's an organized spread. It's not chaotic. A chaotic spread might cause somebody to lose consciousness, like with a seizure. I tell people, think about a soccer riot is a seizure. Think about the wave at a baseball stadium being like a migraine. Because some nerves are getting excited, the ones next to them get excited, and then the ones next to those get excited, and you have this slow progression of electrical activity around the brain. And unfortunately, that electrical activity is a little bit inflammatory. It's not necessarily like it will cause a bit of an inflammation cascade, but it's still generally not overly painful until we start pulling in some really important molecules. Now, I'm going to try to intentionally not throw out the names of brain centers or important chemicals, except for this one, which is called CGRP, calcitonin gene-related peptide. Now, the reason why this is so important is because there's all these medications that target this now. We see these on commercials, and it's such a critically important neurotransmitter when it comes to migraines. Now, I mentioned earlier that that our brains don't really have pain fibers, but we do have a lot of fibers that can sense pain and blood pressure change, and just any sort of pressure change in the blood vessels of the brain and in the lining around the brain. Now, when this CGRP starts getting pulled into a migraine, we get a release of that onto the blood vessels. Now, the purpose of CGRP in the body is to protect us when we start having reduced blood flow to a structure. Think of like a heart attack. If somebody has a blockage of a coronary artery and their heart's not getting enough blood flow, the body will release substances like CGRP, and the purpose of it is to dilate, open up that blood vessel again, but also make it sensitive, because we need to know that our body is under danger of damage, like a blocked heart artery. So in the brain, when you start having this neuroinflammation of the aura, it starts to narrow the blood vessels a little bit. We get the release of this CGRP chemical, which causes the blood vessels to dilate again and become sensitized. Okay? And that's one of the critical parts of a migraine. Now, if I normally ask my teenage patients just for fun to keep myself entertained, I say, what do your blood vessels feel like in your brain? And of course, there's no answer, because nobody knows what a blood vessel feels like in their brain. We don't have a part of our brain that is mapped to that. That's like saying, what does your tail feel like? We don't have tails, so it's impossible for us to know. But those blood vessels send information into a really critical part of the migraine brain, which links up really closely with sensation around the face, specifically around the eyes. So that's why people, when they have a migraine, will often feel this intense pain behind their eye or around their eye or around their temple. And they'll often describe it as a throbbing type of pain. Why is it throbbing? Because the blood pressure, it's the feeling of their heartbeat in their brain that this chemical has made sensitized. So to come back to what you had asked before, what is a migraine? A migraine is this disorder where the brain, for whatever reason, which I'm sure we'll get to a little bit later, goes into a cycle of releasing chemicals that makes your own blood pressure cause pain. Now, that's not the only thing that goes on with a migraine, but that's the beginning of it. The other things that are hallmarks of migraines is that it changes a lot of other nervous system activity. People will become tired, have a hard time focusing. They'll have difficulty with temperature regulation, so they'll feel overheated. It'll hurt to move. They'll feel sensitive to light, sensitive to sound. They might feel sick to their stomach or even throw up. And so when you look at a migraine, it's pretty clear. It's pretty, for most people, pretty easy to recognize. Someone starts getting squinty, they feel sick, they're kind of slow when they're processing of information, they might get a little bit pale, and they just say, I'm sorry, I need to go lie down in a cold, dark room, and if I could just go to sleep. There's something about a migraine where it's intuitive that if you can just go to sleep and reset your brain, you'll wake up and you'll feel a whole heck of a lot better. And all of that is the migraine.
Got it. And why do some kids, teens, develop migraines while others don't?
We don't fully know that. I mean, there seems to be a genetic heritability to it. The rates of migraines increase with other pain problems. So, for instance, the rates are in young school age children, kindergarten, first grade, second grade. Boys are actually a little bit more common, at around 5% of all boys. And girls are a little bit less common, around 4% of girls. As you start getting towards early teenage years, it increases. The boys stay at 5%, but the girls will go up to about 10 to 15%, and then it'll increase to adulthood, which is about 20 to 25% of adult women will experience, will have a migraine disorder.
Do you need a family history of migraines to have a migraine, or can some kids just develop migraines without a family history?
You absolutely can develop migraines without a family history, depending on the triggers. The migraine history, it just adds likelihood to developing the migraine.
Got it.
So a little bit of a genetic vulnerability. Like most things in chronic pain, it probably requires more than one hit,
Mm,
meaning that, you know, you might have this genetic vulnerability plus you got COVID or had a concussion or had your menstrual cycles or what have you.
got it. Got it. Um, what are some common triggers for migraines? How can you identify them, in kids and teens and adults?
Well, identifying and managing migraine triggers is 50% towards treating a migraine. It is critically important. For people who are able to identify that easily, managing their migraines is not very challenging. For people who have a hard time understanding that cause and effect in their own life, it can become more challenging. So some of the major triggers, the big five, are getting dehydrated or not hydrating enough, getting overcaffeinated, not sleeping well, not eating well, and stress. But all of those things, at the end of the day, cause a physiologic stress to the body.
Mhm.
Um, but other ones that are a little bit less common that we see in teenagers, but more common in adults, include weather changes, which are probably more related to either barometric pressure changes or the visual light of going from, say, a bright sunny day to a dark thunderhead day.
Mhm.
Um, and just the way that the light is hitting your eyes differently. Um, Menstrual cycles is a very big one. It generally is before the menstrual cycle starts, not necessarily in the middle of it, but it generally starts a few days before and then kind of goes through the middle of the menstrual cycle. Um, Other ones that we can see are dietary triggers, like specific dietary triggers. These are more common in the ones who have very occasional migraines or they're a little bit older, but in adults it might be things like red wine. In younger people, it might be chocolate or caffeine intake. Um, People talk about, the nitrites that might be in a substance as triggering migraines. Um, Salamis, cured deli meats, those are all possible triggers.
Are there certain foods or activities in general that are likely to produce a migraine?
Well, I think it depends on who we're talking about. Somebody who has migraines or somebody who doesn't. I've started to compare having migraines a little bit like having asthma. And I say that because asthma is so common and that people seem to understand it more. I have a cat that's actually jumping around my room right now, And I don't have asthma, so I don't have any problems with it. You take someone who has asthma, the same cat might trigger their asthma.
Mhm,
So in people who have, but they could have asthma and not have an allergy to cats.
mhm,
So sure, there are things that are likely to trigger migraines in all people. Most commonly right now, it's concussions and COVID are probably the two. Like if you don't have migraines, you might get a migraine if you get COVID. Um, Viral infections in general, but COVID specifically. But if you do have a migraine disorder, it tends to be a little bit more unique to you as to if there's any specific food or trigger, or exercise trigger. But especially if somebody is underhydrated, undernourished, or sleep deprived, it a lot of different activities can tip them over the edge if they're already in those situations. And as you know, Dr. Zeltzer, with teenagers these days, most of them or many of them are underhydrated, undernourished, and sleep deprived.
right, given. And what about when should a parent or a young adult consider medication for migraines?
Mm.
Different from taking Advil or a leave.
So when we think about migraines, it's really important to break it into the acute rescue and the daily prevention. Okay. For the acute rescue, there's not many things that work better than a migraine medicine. Though there are a few devices that are coming out that can be quite helpful at rescue from a migraine. When you get to the daily preventatives, it's a completely different decision making. So I'm going to break them up and answer your question in both categories. With an acute rescue, migraines are a very disabling disorder. They're painful. They can suck away your entire day. So the job of a migraine medicine is to help you is to get you out of pain, get you back on your feet, and help you recapture your day. We generally recommend medicines pretty early for that. We would want people to have the right tools to knock out their migraine. It might be just ibuprofen. That might be all that's needed. For people who are not frequent coffee users, an ibuprofen and a cup of coffee, as an example, might help get their energy back and take away their pain and get them back on their feet. If that's not working, there are some combination products like Excedrin migraine. I don't know if we have to be careful around recommending specific brands here, but and that has caffeine in it, as well as an anti-inflammatory. And then you move on to some of the migraine specific treatments like triptans and the new ones, which are G-Pants, which have all the commercials right now. Ubrelvy, Nurtec, Qulipta, things like that. So that's one category. We have a very low threshold for using medicines. Again, going back to our asthma analogy, that's like saying albuterol. We need albuterol to help breathe in the midst of asthma. But when we start moving towards a daily preventative, we want to be able to use as many non-medication strategies as we can. Again, going back to an asthma analogy, very often people get put on medicines, like a daily medicine. But really, the thing we ought to do is we ought to be making sure that no one is smoking cigarettes around them first. And maybe we want to look into the environment first. There's a number of things that we should be tackling first before we put somebody on a daily medicine in an ideal world. So when we ask the question of, do we need to put somebody on a medication, it gets a little bit more complicated. The, you know, the short answer is 4 or 5 migraine days a month is when we say, all right, we probably need to put you on a daily controller. The thinking behind that is if you were to be having migraines more than 5 days a month and you're needing to use medicines like ibuprofen more than 5 days a month, the medicines might start giving people migraines. So we try to prevent it down less than 5 migraine days a month. But ideally, you would do that by identifying what their triggers are and you treat those triggers. Get somebody to hydrate if they're not hydrating well, or if they are hydrating well, work on their sleep. If they are over caffeinating, make sure that we're eliminating the caffeine intake, or at least reducing it to, levels that are not big energy drinks with almost toxic levels of caffeine in them. Um, you know, so a lot of migraine management is actually general health management. It's very similar to chronic pain management that you and I both do. Um,
Now, there are a lot of increasing number of advertised mechanical devices for migraines, Nurtec, and I mean, there are all of these increasingly advertised things that are mechanical devices that you have to buy. You may have to subscribe to, 12 sessions of, and then you have to pay for more. Can you
mm,
talk about some of these?
sure.
What, people ask about that?
Sure. Yeah, there are a number of different FDA cleared devices for the treatment of migraine. And so FDA cleared is the same thing as FDA approved, but for a medical device instead of a medication. So these all have gone through scientific rigor. Um, and there's a few brands out there just to say their names. So you have the Cephally device. They all work a bit differently. The Cephally device essentially acts as a transcutaneous nerve stimulator that stimulates some nerves that feed into that same migraine part of the brain that we described earlier. That can be used for both an acute rescue if you catch it early into an attack, though if you do use it too late in the attack, it might actually aggravate some of your pain. And it can be used preventatively to try to dampen down and retrain the brain centers. You have the gamma core device, which is a vagal nerve stimulator that you hold to your neck that tries to dampen down or tries to increase your vagal nerve activity. You have the Nerivio device, which goes on your arm. The Nerivio device it tries to engage conditioned pain modulation. So the same parts of our brain stem that can provide pain relief when we do deep breathing or guided imagery. This is trying to bolster that with a device that you wear on the arm. There was one that was a transcutaneous magnetic stimulator. I'm not sure if it's available anymore, but that one went around the back of your head and it provided a magnetic stimulation to try to reset some of those brain centers. These are
Oh,
all FDA cleared, and we do recommend them. And unfortunately, there's no way to predict which device somebody will respond to. So we have to not only weigh into the risk and benefit, like how likely is this to help? Are they going to have any medication side or device side effects? But also, are they going to be out money with something that won't work? So for instance, the Cephally device offers a 90-day money-back guarantee. So for a lot of my patients who are experiencing financial limitation, I say, let's just start here. And it can be expensive, but I tell people that you'll know if it's worth it. Like if you try it and it's working where nothing else is worth it, you just do everything you can to afford it. But if you're saying like, it helps a little bit, but not enough, then return it.
oh, that's helpful. And that's for intermittent migraine, not for chronic migraine, right?
Right. So you can use it for chronic migraine. They have it as a daily preventative, but obviously you're going to be using it more. So the cost will go up. If you have something that is going to be, like I think for the Cephally device, what you purchase are the stick-on pads. And so you can reuse them, but the more that you use it, the more likely you're going to need more.
And a lot of neurologists recommend Botox. Can you
Mm,
explain where and why and how?
yeah. So, Lonnie, you and I, we work on the mind-body connection, and that being said, I do Botox. I love Botox. I think it works wonders for chronic migraine. Okay, and the way that it works, is Botox gets injected at these very specific sites around the head and the neck. Many of those sites overlap with acupuncture points, which is one of the reasons why, as an acupuncturist, I find Botox so interesting. I like to think of it as acupuncture, but we're dropping a medicine in there that lasts for 3 months. Now, people think about Botox when they think about wrinkles and, like the 11s and the forehead rhytids. Um, Botox in those situations inhibits the nerve firing on the muscle to make the muscle weaker. It just weakens that connection. When you use it for chronic migraine, it's not only weakening some of those muscles, but it's actually weakening the nerve firing going into the brain. So it's reducing some of the sensitivity of the nerve endings firing into the brain. And that can help down-regulate some of the pain centers in the brain related to chronic migraine.
Mhm.
So with Botox, it's normally a very, very small needle, a little bigger than an acupuncture needle, but not as big as flu shot needles, to put it in context. You get them in 31 locations, unfortunately. Those locations are here between the eyes, around the inner part of the eyebrows, across the forehead, the temples. You have 4 injections over there, 4 injections here, 3 along the back of the head, 2 at the upper neck on each side, and then 3 or 6, 3 on each side down in the trapezius muscle. It lasts for 3 months. It is FDA approved in adults for the treatment of chronic migraine, and it used to be the only FDA approved treatment for chronic migraine. And we see great results with teenagers. One of the interesting things, there's not a lot of studies about this, but there was one adult study on this that suggested that adults with anxiety, especially anxiety contributing to their migraines, actually have an enhanced response to Botox. Because when they have their anxiety and their muscles are tight, it's like that progressive muscle relaxation, but you're kind of forcing them into it. And you're helping them relax muscles that are kind of hard for a lot of people to relax, like the frontalis, people who might walk around with a kind of a surprised, engaged face. These muscles are could just be elevated. Your eyebrows might be elevated all the time. The occipitalis is a hard one to relax, you know. So it can work really, really well. It's something that you do 4 times a year. Overall, the side effects to it are pretty low. The hardest part about it is just finding a doctor who knows how to do it in a pediatric manner.
Mhm. Yeah, and I hear from some of my young adults, older adolescents, that they'll go to one neurologist who will then say, oh, you had Botox from Dr. So-and-so. They didn't use the right protocol. And,
Mm.
is there a standard protocol or is it,
There is. So it's called the preempt protocol. And this was the protocol that was studied by the makers of Botox and when they put forth the FDA approval. So most insurance companies will only cover it if you do it with that protocol. It's a very expensive protocol though, because Botox is expensive and it's a lot of units. So sometimes people will go to I don't see this a lot in the in where I live. You might in LA, but they might go to an esthetician or somebody who's doing Botox for wrinkles, and they'll try to do it more like just cheaper. And so they might put it into the different locations than what I described before, which is the FDA approved protocol.
uh,
Um, and so, or they'll try to do a dose reduced where they might only do the front or they might only do the back, whereas technically you're supposed to do the whole protocol.
uh, typically in adolescence, see migraines starting after other chronic pain has started,
Mm.
irritable bowel syndrome or, post injury pain that keeps going or CRPS. Like, why is,
Oh, Oh, we do. Yeah, we do. It so it could very well be a few different things, and I don't think anybody fully knows. So I'm just going to speculate a little bit, if that's okay with you. So I think the thing that we all know is that when you start getting into very frequent headaches, it's a chronic pain condition just in a different part of your body, and we know that the chronic pain condition can start to overlap as the central nervous system gets sensitized. So that central sensitization where the nervous system has become sensitive to things that cause pain, absolutely can start to pull in other areas of pain like migraine. But the plot, and I'm going to go into a little bit more detail just because I think you said you had 3 clinicians, and I don't know what our clinician audience will be, but it can get a little bit thicker. So if somebody's having chronic knee pain and chronic back pain, and they're given anti-inflammatories to treat their back pain, well, those anti-inflammatories can actually cause your body to release more CGRP. So that can start to trigger the migraines.
Mhm.
So not only can the sensitization of the nervous system contribute to people developing migraines, but the treatment for certain chronic pain disorders can end up triggering migraines. Or if somebody has IBS and they are maybe not eating as much as they used to,
Mhm.
then that malnourishment can trigger the migraines. And so when we're looking at somebody with overlapping pain conditions, first this started and now the pain starts to spread, understanding the chain of events becomes so important for trying to break the conditions back down. And what I mean by that is if somebody develops IBS and then, or a chronic nausea condition, and then they stop eating and they start developing migraines, the best treatment for them is to get them eating again, treating the GI problem.
Mhm.
If somebody developed back pain and then they start developing migraines, we want to not only look at the medicines for migraine, but also look at the muscle tension that might be spreading up their back to their neck. And instead of giving people multiple different types of medicines that don't, like for instance, topiramate won't do anything for back pain,
Mhm.
giving that for migraines, whereas giving, you know, anti-inflammatories for back pain, trying to unify that and say, is the muscle tension the cause of both?
Mhm.
So it becomes really nuanced really quickly. And, as you know, Dr. Zeltzer, it's really hard to find one person to treat more than one problem. And so, you end up having different people with their own lens on it and not necessarily seeing the big picture.
So I have some patients who are on topiramate, Topamax, and it's been hard for them to wean off the Topamax, but it affects their memory. They call
Mm.
it Topamax.
Hmm.
How do you work with that? And yeah,
Well, I have to look to see why we think that topiramate is working so well for their migraines. When you say in your patients, they're having a hard time weaning off because it's working to treat their migraines, or they're having some sort of
no,
withdrawal from the medicine?
no, it's
Just because it's
working.
working?
It affects their cognition, so they want to
Mhm.
try to get off the topiramate, but every time they lower it too much, they
Mm.
start having more migraines.
Mm. Well, so that's a really interesting question. Um, to keep on my theme of giving more information than you're asking. So the CHAMPS trial from a few years ago
Right.
suggested that topiramate really wasn't any better than placebo for the treatment of migraine for occasional migraines. Now, what are some of the other things that topiramate does? One, it lowers spinal fluid pressures a little bit. So it's really great for people who have some high, even if it's not a disease level high spinal pressures, but just a little bit higher than typical. It can lower that. Those might be people who are sensitive to barometric pressure changes with weather. It cuts the appetite a little bit. So topiramate was, I don't know how long ago, 20 or 30 years ago, actually looked at as a weight loss drug before we've got the Wegovy's and the Ozempics. So it can be really, really helpful for that adult patient who, like most of us, me, maybe not you, Dr. Zeltzer, who would love to lose 5 or 10 pounds. Topiramate works really, really great. For teenagers, though, a lot of them, not only can it cause the thinking side effects, but many of them aren't eating very well to begin with. There's also huge overlaps between ADHD and migraines, as high as 30% in some studies. So you have a kid who's on a medication to treat ADHD that's cutting their appetite, and then we put them on topiramate, which is going to further cut their appetite. We can have some problems. So I say all that to say we kind of have to, I would like to understand what it is about the topiramate that seems to be so helpful. There is a sister medicine called zonisamide that is in the same class that does have fewer cognitive symptoms, side effects. So sometimes it's as simple as rotating from one to the other. There's an extended release topiramate that might reduce some of the side effects by having less of the peak and the trough. So it's just a little bit more steady throughout the day. But other times I would want to know, is this exposing the ADHD? Like, did they always have some problem thinking and the topiramate's just worsening it? Maybe in that situation, we have to treat the ADHD that was kind of in the background, but has now stepped forward a little bit from the topiramate. So it's a little bit nuanced in understanding that situation. But I love that kind of detective work.
Yeah. You know, dysautonomia, and
Mm,
it's because, you know, I'm seeing more and more kids who are coming in and saying, we have POTS. We went to cardiologist or POTS clinic and we have POTS. And, you know, and they talk about all of the dizziness and, you know, and they're drinking and they're having salt and they're, you know, having support, but on their support hose, but they're still having dizziness when they stand and whatever. And they say that, you know, that's sort of connected. They started getting migraines with
mhm.
anomia, or once they started getting migraines, they developed dysautonomia. Can you kind of talk about that?
Sure. So I didn't use these words before, but a lot of the symptoms of migraines are autonomic. And the blood flow changes that occur in the brain are under autonomic control. So when somebody develops a widespread dysautonomia that's affecting their heart, it's affecting their gut, all you have to, it's not a huge leap of logic to say that it's also affecting the blood flow control of their brain, which might make them more predisposed to developing migraines. Because remember, if it starts to constrict down, then your body releases that CGRP, which is autonomically active, by the way. Then it will trigger the migraine. Now, if somebody starts with migraines and then they start developing signs of dysautonomia, you know, very often in that situation, I hear a story that somebody had a viral infection like COVID or they had a concussion, and that we know that those are triggers for chronic pain disorders in general, and dysautonomia being one of them. But there's a very real overlap. Now, I will say that what I observe, and there has not been a lot of research into this, but what I observe is that people with dysautonomia and migraines don't respond to migraine rescue meds the same as everybody else. Just sometimes it works, but it's those medicines work so well on average for people with the occasional migraines that then develop over time versus somebody who's got the widespread dysautonomic picture. In those patients, um, you have a lot more, I see a lot more overlap with the musculoskeletal system. Sometimes I even wonder, again, not for all patients, but is it, are they actually linked? You have a head pain from muscle tension, and we think it's a migraine because we're seeing all these autonomic symptoms like nausea and light sensitivity and sound sensitivity. But instead of that being a migraine, they're actually muscle tension and dysautonomia. And that's why the migraine medicines aren't working, is because it's not a classic migraine. It's just kind of separate.
Right,
Almost like if we were to go back to our asthma picture, if somebody developed asthma and they had a hard time breathing because the airways are narrowing, we use albuterol.
right,
Albuterol stimulates you, it opens up the airways. But imagine if somebody has anxiety and a panic attack and they're having a hard time breathing and we gave them albuterol. That's going to overstimulate them. It's not going to help. You might have the same symptom of difficulty breathing, but completely different treatments.
got it. We have a bunch of questions here, so I'm gonna start asking. Um, a lot of neurologists recommend Butterbur. Does that help prevent migraines?
Butterbur does have some research to prevent migraines. Yes.
Okay. And then somebody else, I'm going to read this. Hi, my daughter had concussions 6 months ago. She just recently started taking CGRP and Emgality for migraines. It's helping only a little bit. How do I know if she truly has migraine or just headaches? She's had a headache every single day since the injury, varying in intensity with and without medication. She has tried it all. That doesn't sound like migraine to me. You want to comment?
Sure. So concussions causing headaches, migraines is absolutely a possible cause for that, but it's not the only one. So you can have musculoskeletal contributions, um, like a whiplash type injury that can affect the nerves as they go into the migraine centers. It's a condition called occipital neuralgia, and that can cause headaches that look a lot like migraine, but aren't migraine and don't seem to respond to the migraine medicines as well as one would like. They tend to respond a bit better towards a mixed nervous system and muscle-based treatment. So the physical therapy, I find acupuncture can be really helpful in those situations, or dry needling to try to work on some of those up there. And those are those perfect examples of when we use Botox, because we can relax muscles that might have gotten very tight and sensitive from the concussion with the whiplash injury.
Got it. So another question. A neurologist told me that using caffeine and over-the-counter meds like Advil can cause a migraine. Should they be used or avoided?
It's a matter of degree. So use of ibuprofen or Advil more than 12 days a month is associated with migraines getting worse over time. With caffeine or coffee, it's the same thing. It's a matter of degree. So if somebody is having, not everybody gets these, but people who have migraines are more likely to get them. So if somebody can drink a pot of coffee a day and doesn't have any problems with headaches, then there's no problems. But if you notice this trend that somebody is using a lot of ibuprofen or using a lot of caffeine, and it is the headaches are getting worse over time, we have a suspicion for it. Now, telling somebody that, hey, this thing that you like or is helping you might be giving you this problem is a really uncomfortable situation. Because, for instance, if somebody starts using ibuprofen, a very classic situation is after a concussion, and they're using ibuprofen every day for the concussion, but it starts to continue. um, all the other concussion symptoms get better except for the headaches. One of the causes might be that this ibuprofen that somebody is using for their headache is now giving them the headaches. So you have to ask them to stop the thing that they're using to treat the headache. And it's so uncomfortable to put somebody through that when you can't even guarantee that it'll help. So a lot of neurologists will just say, you know what, I don't want you to use much ibuprofen at all. They'll say like no more than 2 days a week. And that's a pretty safe place, once or twice a week.
Got it. So somebody else asked, have you seen TMS, transmagnetic stimulation, helpful for headaches?
So when we're talking about TMS, and I think there's this next question about ketamine, we're in the Hail Mary zone of treating headaches. So in the Hail Mary zone, of course, there are all, yes, you see people who get benefits from it. How likely is somebody to get benefit from it? It's hard to say, because they're so challenging, and there's so many different layers to what goes on when you get to that level. It's hard to say that there's a one size fits all. For TMS specifically, there was that device, the name came to me, it's called the e-neuro device. Again, I don't know if it's still available on the market, but that was FDA approved for the treatment of migraines. You could just get it at home. It sat like a horseshoe around your neck. So based on that FDA clearance, I would assume that more sophisticated TMSs would help, but I don't know if there's a lot of data behind it, which doesn't mean it doesn't work. It just means it hasn't been well researched. For ketamine, which I think was the next question, ketamine doesn't have as much research behind it as it does for other pain conditions, and there's not even a lot of research for the other pain conditions. But that being said, do I use ketamine if we've thrown everything else at it and it's not helping? Occasionally. I think it depends on the cause. I think
Mhm.
it's less likely to help with migraines than it is to help with other causes of head pain, especially if somebody's in a whole body pain state, is when I think about using that ketamine. So if it's just headaches and it's chronic migraine and it's pretty clearly chronic migraine, I would not be thinking ketamine. If somebody's whole body is hurting, I think I can think of one patient who has multiple sclerosis that I've taken care of, who has really tough problems with headaches, but it's not from migraines. Ketamine might be very helpful for that patient.
Right. What about the kid who finds school stressful and they have migraines and then going to school, trying to concentrate, being in, how do you deal with that? And the kid who says, I I can't go to school or starts missing a lot of school because of
Mm,
migraines. And then, school says, well, you could do it online. Well, they can't do online because that makes their headache worse. Can you
right.
talk about that?
Oh yeah. So it's very, very challenging. It's very challenging. Um, I am not the biggest proponent of online schooling, especially for folks with migraines, because light sensitivity or screens can be one of the major triggers for the migraines. I don't fault people who do it. I understand why they do it, but I'm never recommending that. Um, I like to start at the end of the story, which is to say we want kids to go to college. And so, we want them to be able to work in the workplace. We want them to be able to have families someday. And so we don't really get there by pulling back in the face of adversity. We have to move forward in the face of adversity. There's a lot of different things that can throw extra wrinkles that can be challenging. It's way easier to manage this type of problem in a good supportive school than it is in a school environment that has become adversarial, where the family feels like the school is out to get them. They're calling the truancy clerk, or maybe the court's involved for truancy, in which case that situation is so stressful that that could give anybody migraine, even people who don't get migraines. Um, so you have to kind of pick the things apart. But in general, I like to start with there are things that we have to do, and we have to attend school face to face in my value system. If a parent has a different value system, that's fine. I go with their value system. So in no way do I tell people what they have to do. Um, then you work with the school to try to identify what those triggers are. We try to, again, look through the big five. Are you eating enough? Are you hydrating enough? What does your stress look like? What does your sleep look like? What are other things that are going on at school? When somebody has a really frequent headache and they're having a hard time drawing cause and effect because so many different, especially if they're a teenager, so many different things have given them headaches that they have a hard time seeing the forest from the trees. This is part of that ADHD that can overlap with migraines. So I asked them, let's talk first of all, is it more common on school days or weekends? And they'll say it's both. And I'll say, yes, but what's more common? And most of the time they'll say it's school days. Say, okay, what time of school? I try to let the timing of the headache give me some initial clues as to the causes. So if somebody says, oh, it starts before I go to school. Okay, well, that's helpful. Is it starting at 10 or 11 o'clock? Did they skip breakfast and now it's 10 or 11 o'clock and their blood sugar is dropping? Maybe they're spilling over into a little bit of ketosis and that triggers it. Is it during lunch when there's just a lot of noise going on and people are, I don't know if they do spitballs anymore, but you know what I mean? There's a lot of noise in the lunchroom and that's overstimulating them. Is it after lunch? Again, did they eat lunch? Were they hydrating? Did they have caffeine? It's a kind of appalling to me that they sell sodas and energy drinks, at least in the high schools around where I live. And so you have to really get down to like, what did you eat for lunch? What did you hydrate? Did you have a bunch of caffeine? If it's happening towards the end of the day, is your brain just tired? Like, is it not one specific thing, but you just feel that brain drain where you're just kind of worn out? And all of those things have nuanced treatments when you really get down to the nitty gritty. Um, I don't love giving people headache diaries because I don't want them to focus on the pain. Um, but this is a situation where you really do want them to keep track a little bit because you're trying to identify not the level of the pain, or focus on it, but help us be detectives. So just keeping track of a hydration log, headaches, nourishment, and um, it can be as specific as my Spanish teacher is really mean and I'm hard of hearing, and she doesn't understand that I can't hear her. And then she's really mean and nasty to me. So I'm feeling a lot of stress. And the problem is that I'm sitting in the back of the class and I just need to move to the front of the class and have a sit down conversation with the teacher to stop being so mean to my child. Like that's the nuance that we have to look for.
One question that often comes up, are migraines dangerous? Are they
Mm.
life-threatening?
Migraines are not dangerous. Thank the Lord, our brain has an escape. So like when our blood vessels start to constrict down, the migraine is actually part of the opening back up of the blood vessels to prevent us from having dangerous consequences. Now, you can get into some nuance. So women with migraines with an aura have higher rates of blood clots than women with migraines without aura. So meaning that if somebody has a migraine with an aura and they're on an estrogen containing birth control and they are an adult and they're smoking and no one should be smoking, but they might actually have a fairly high rate of having a stroke or having a blood clot. So migraines are not dangerous by themselves, but it does change your risk factors and it's probably that the risk factor with migraines is that initial narrowing down with that migraine with the aura in somebody who's also on an estrogen containing birth control. And it
Mhm.
might be that two hits of slowing the flow just enough to cause a problem. But that's also very rare, but it is a statistically real sample.
Yeah. So we know that stress can trigger migraines, and we know that if you have migraines, you're stressed. This idea of going to a psychotherapist and getting help, what kind
Mm,
of help, what's been studied, how does that work how does psychotherapy and what kind work
mm.
for migraines?
Yeah, that's a great question. So I have a lot of patients who feel a stigma at the topic or the idea that doing something called cognitive behavioral therapy can help them. Um, and what cognitive behavioral therapy would do for somebody with migraines is actually a lot of that nuanced like conversation that we just talked about, helping a kid see the cause and the effect, helping them understand their own emotional state, and intervening early. When you're working with teenagers, here's a very common situation that CBT will be helpful. We know that treating a migraine when it occurs early helps somebody recover their day. Their migraine might occur in fourth period right after lunch, and we're trying to get that to be less common. But we've gotten some medicine. The school has the medicine. All the kid has to do is raise their hands, ask to go to the school nurse to get the medicine. But they don't want to be they don't want to be viewed as being different. So they don't raise their hand. So they suffer with the migraine for a few hours until they get home. But by that point, it's really hard to recover them. So what CBT in that situation is say like, hey, your migraine stinks. Why are you so worried about raising your hands? Like migraines are common and just challenges that thinking a little bit. Like it's okay to be different.
Mhm.
It's okay to need this. And then maybe helps them learn how to advocate for themselves better, help come up with healthy habit systems so that they can remember to hydrate when they're focusing on the schoolwork. But it's like, how can you take care of your body while you're focused on something else, engaging like learning? So most of it is not what we would call like true mental health work. a lot of it is just around trying to take the control that somebody needs during the school day to help take care of themselves.
So I'm thinking a lot of parents of the adolescents, young adults are perimenopausal.
Mm,
And so you see, you hear parents talking about not having migraines before, suddenly they're having migraines. And what about their parents who have talked, and this is more from parents than kids, parents who have talked about getting an aura but no subsequent head pain, and
mm,
or having a period where they get vertigo, and it's, they've been to ENT, it's not in her ear, all of that. They have
mm,
vertigo but without head pain, but it's, it still flattens them out. And
right. Yeah, so migraine aura without headache. The old term for that was acephalalgic migraine. So migraine headache without aura. I'm sorry, migraine aura without headache. Is a really fascinating and poorly understood condition. It's probably at the end of the day, it's probably that sensitization of the nervous system, central sensitivity that has a start and a stop, and you just don't have the headache. Some people might feel hot and flushed in the early afternoon, um, like after a lunch, like that food coma where they're feeling sluggish, but they're also sensitive to sound, a little bit irritable, a little light sensitive. Um, that might be a migraine aura without a headache. I
mhm.
think I get migraine auras without a headache. Part of what makes this resolve or makes you more suspicious for it is if you go to sleep and then you wake up and you're feeling better, like it's just completely resolved. So a migraine aura is by definition, it's a temporary state of altered nerve activity that resolves within a short period of time. Now, is that dangerous when with migraine headaches with aura versus just the migraine aura? We don't know. That hasn't, that's a great question, but we haven't, that has not been well studied.
Mhm. And what about vertigo and without a headache, but,
Mm.
developing perimenopausal, and again, some of the
Mm.
parents of kids?
So vertigo and migraines are really highly overlapping. 30 to 50% of people with migraines will have vertigo episodes. And so there's strong overlap with family histories. So, and that vertigo is the central sensitivity of the nervous system. Now, I think there's a little bit of a cause and effect. So, for instance, in my concussion practice, kids who have some motion sickness before the concussion are the ones who are most likely to get vertigo after the concussion. And they are most likely to not get better very quickly. And so it could be that the underlying motion sickness and vertigo might be one of their migraine triggers. So if they were to shake their head a bunch, spin around a bunch, they're going to get a migraine. Um, but there's this huge overlap. And so I think of it as that part of the brain is just always close to tipping them over into a migraine. And in those situations, vestibular therapy, there are rehab therapies that can be helpful for that type of thing these days. Um, so thinking it from a very mind-body connection, I mean, those are, I work with vestibular therapy almost as often as I work with our physical therapists these days, or when we're treating with migraines. I probably would use vestibular therapy just as much as I use treatment around like muscle tension.
And vestibular therapy, you want to just
So you're retraining you're retraining and rebalancing the coordination between the inner ears and the eyes. So, in your position sense. So basically treating that vertigo-like sensation. So there's different ways, different physical exam findings that can screen for that type of vestibular problem. To the speaker who had mentioned before, or not speaker, the questioner who had asked about the concussion, that is a very classic example of somebody who's continuing to deal with headaches 6 months after a concussion, is that the dizziness from the concussion is still going on and one of the major triggers. And vestibular therapy could be gold for somebody like that.
and where do people go for vestibular therapy?
So vestibular therapy can be offered by physical therapy or occupational therapy. But you need somebody who is trained in it. It's an extra level of training. So Oftentimes, if you ask for a concussion physical therapist or a concussion specialist, they can help you find that person in their practice. It's so common, though, in the concussion population that most sports medicine practices have somebody who specializes in it.
Got it. Well, we're at the end of our time, and I want to thank you so much. This has been super informative.
It was a pleasure.
Bye-bye.